So next is hepatocellular carcinoma. It's V2, and a 65-year-old male with a history of non-alcoholic steatohepatitis presents with weight loss, loss of appetite, and vague discomfort over the right upper quadrant. On examination, he is mildly jaundiced and has hepatomegaly. How would you investigate this patient? The patient is at risk for liver dysfunction and also development of hepatocellular carcinoma. A thorough history, then examination. In history, particularly, we will ask about the alcohol intake, hepatitis B, hepatitis C exposure, and risk behavior. And then we will do examination and investigation. Investigation, we will do liver function test, full blood count, alpha fetoprotein, and request ultrasound scan. If ultrasound scan picked up any suspicious lesion, that can confirm by CT or MRI. The ultrasound shows a 3 centimeter lesion in the liver that looks like a hepatocellular carcinoma. How would you confirm the diagnosis? Ultrasound is a useful screening tool, and it is, however, unable to diagnose HCC as the prognostic features are non-specific. HCC can be diagnosed if number one criteria, if someone has alpha fetoprotein more than 400 and CT features show HCC. Number two, who have two imaging, CT and MRI both are diagnostic. And number three, there is no need of biopsy. If we do biopsy, there is 1 to 3% chance of tumor seeding. What are the typical features of hepatocellular carcinoma on the CT? Because it's a very vascular tumor. So first of all, it will solid vascular tumor. So first of all, it will be heterogeneous appearance of the tumor. Number one. Number two, it will enhance on the arterial face, and it will be rapidly wash out in the portovenous phase, delayed phase. And sporting features include the portal venous invasion or thrombosis, hepatic vein invasion or thrombosis, and liver cirrhosis and associated sequelae on the imaging like varices, ascites, or splenomegaly. And the lesions which are smaller, 1 to 2 centimeter, they are too small to characterize on the CT and MRI. They need either MRI with gadolinium contrast, or they need a repeat CT at 6 weeks or 3 months time. What are the risk factors for developing HCC? The risk factors are hepatitis B, hepatitis C, alcohol intake, and any other cause of liver cirrhosis like hemochromatosis, alpha-1 antitrypsin deficiency, and primary biliary cirrhosis. More recently, there is also evidence that non-alcoholic steatohepatitis is also a new predisposing risk factors. How do you screen and follow up patient at risk of developing HCC? So we have to do the predisposition of HCC are well documented, and the patient who needs screening of hepatitis B or C or have evidence of liver cirrhosis, and the protocol is ultrasound scan of the liver, alpha protein, and liver function test every 6 months. What factors contribute to the prognosis? So again, there are different classifications, but the factors which are prognosis would indicate the following: the tumor size, number 1, number of lesions, number 3, vascular invasion, number 4, portal thrombosis, number 5, extrahepatic invasion like diaphragm adrenal, number 6, tumor rupture, number 6, extrahepatic disease. Thank you. And what are the treatment options? So again, like all other solid tumors in the body, for HCC, options include the resection or transplantation. And in patients with appropriate liver function test, even in cirrhosis, resection is a good option. The issues with the transplantation that include donor organ availability and long-term sequelae of transplantation. So this is primarily when the patient are of good child-POF scores A and B. For patient with poor liver functional test, liver transplantation is the ideal option, as it involves both HCC and also liver dysfunction. However, the strict guideline like Milan criteria, which includes that either tumor is 1 and less than 5 centimeter, there are 3 tumors, then each one is less than 3 centimeter, there is no extra hepatic invasion, and there is no any major vessel involvement, then they fulfill the criteria for liver transplantation according to Milan criteria. There is a score called modified end stage liver disease. It includes 4 factors: dialysis frequency each week, creatinine, bilirubin, and INR. Another one is called child puff, which has 5 parameters. 2 are clinical, ascites and encephalopathy. 3 are biochemical, albumin, INR, and bilirubin. And next is When surgery is not an option for any reason, any treatment option exists and can be broadly divided into the direct tumor ablation in the form of microwave, cryotherapy, or radiofrequency ablation, or transarterial delivery method like ethanol, trace, or the systematic treatment like sorafenib or nivolumab. Thank you.